All right, part two. It was more than a few seconds, but you won't know that. Um, you do now. So talk a little bit, just kind of briefly about sort of the lifespan influence of mood disorders. This starts very early. Infants can show symptoms of depression. There's some research. I don't really know much about this research. It sounds a little like, you know how, like when you're seeing babies and people think they smile, but then people say it's just gas. I don't know how anybody knows that stuff with babies. But there are studies that say, and your textbook says that 3-month olds can show signs of depression. So I don't know about the science there. I don't know how valid that is, but there's multiple studies that suggest that. Actually, in my undergraduate studies at UK, I was involved in a research study that looked at depression in infants, but it went on for many years, and I never saw the outcome of that. So that's a very useful tidbit for you, right? But one of the things with not infants per se, but younger children, is that they look different when they're experiencing these symptoms. As I mentioned with depression, children show more irritability and less of just kind of the ongoing sadness. They may show more anxiety or more avoidance, so it may look just a touch different. Children are being diagnosed with bipolar disorder now at greater rates than ever in the past, and that gives me a lot of concern. Many years ago, I remember when I first started out in this field, it was general practice that you don't diagnose children with bipolar disorder. There's too much there, too much change, too much instability and emotion. But we're starting to see a lot more of that now. So, I mean, it's something to keep an eye on. Depression in the elderly, somewhere between 14 and 42%. That's one of those ridiculous stats that I think we should not even bother to give when you say somewhere between 14 and 42%. That's such a wide range. What does that even mean? What we know is that depression in elderly happens. There's diagnosed less often than in the general public, but it's still there. And oftentimes it is co-occurring with anxiety. What you do see here is less gender difference in the elderly populations, probably because there's just less stigma related to depression with the elderly, so men and women are more likely to seek treatment alike. Let's see. I'm going to skip some of the... and I'm going to skip some of the sort of genetic stuff, but what we know is that both depression and bipolar disorder tend to run in families. They tend to be inherited, but they tend to be inherited separately. So there's a genetic predisposition for depression. There's a genetic predisposition for bipolar disorder. One doesn't necessarily increase your risk for the other, so it's not a sort of this cross influence. There does seem to be some genetic link between depression or mood disorders in general and anxiety. So you have anxiety in your family history. It does slightly increase your likelihood of having a mood disorder and vice versa. So when we look at some of the causes, we look at the neurological causes. Serotonin is definitely a factor when we're looking at anxiety. In fact, we use selective serotonin reuptake inhibitors, SSRIs, medications that we use typically to treat depression. We use that a lot for anxiety, kind of chronic anxiety. It's medications that tend to last a long time and help regulate the serotonin in our brain. Also, norepinephrine and dopamine or other neurotransmitters that are implicated in depression. But serotonin regulates both of those things, so often all of those things are linked. But mood disorders in general are related to low levels of serotonin. Also, we see like elevated cortisol levels, similar to anxiety. When you are stressed out or depressed, your cortisol levels are increased. Also, you see more or a decrease in or an increase in sleep disturbances. You see more, um, and there's a neurological impact to that as well. And that's common with depression. It's also common with bipolar disorder, sometimes in vastly different ways. And often one of the targets of treatment is trying to help people work through sleep. Sleep disturbances can cause a lot of other issues secondary to just dealing with the depression, dealing with the sleep. It can cause a lot of anxiety, and it can cause some physical distress as well. So we know there's some neurological causes, and we know that a large focus of our treatment is looking at some of those neurological causes, dealing with the serotonin levels. Also, a lot of the modern antidepressants deal on those other neurotransmitters, the norepinephrine and the dopamine, so sometimes all three. But one of the other factors when we're dealing with mood disorders is stressful life events. And you know that. It's very predictable. We're currently living through this coronavirus, and it is certainly qualifying as a stressful life event that's creating havoc in our life and causing a lot of anxiety and depression. And also there's this sort of link between our genes and our environment. People who are more vulnerable to depression might more easily enter situations that will lead to stress. And that certainly isn't applicable to our current situation, but is applicable to a lot of other things. There are certain people who are more likely to enter into stressful situations or engage in stressful activity that will enhance their likelihood of experiencing depression. The stress and bipolar link is also pretty strong. Generally, we talk about stress when we talk about depression, but it's also true with bipolar disorder. It can also often be a trigger for people who are experiencing those types of symptoms. Increased stressors can cause trigger manic episodes, also trigger depressive episodes too, but we've already sort of talked about that, but it can trigger the mania as well. One of the things that we talk about very often when we talk about treating depression is the cognitive component, the attribution styles. People who are depressed tend to have internal attributions, so they tend to say that the negative stuff that is happening is their own fault. I didn't get a job because I was a terrible interview. Because I'm not good enough, because I'm worthless, nobody would want me. So they attribute all bad things that happen to something they've done. They also tend to have stable attributions, meaning this is the same no matter what. The negative outcome will always be your fault and isn't likely to change. And then the attributions are also global, meaning the negative events will disrupt many life activities. So it's going to keep me from getting any job. So their internal negative attributions, they're stable, believing that all the future outcomes are going to be the same. Nothing's ever going to change. Everything's terrible. It's all my fault, and nothing's ever going to change. Nothing's ever going to be okay. So this constant negative way of viewing the world tends to feed depression, and people who struggle with depression tend to have these attribution styles that just feed into the system and make it more difficult. And it's generally referred to as a negative cognitive triad. Feeling that I'm not good enough, nothing's ever going to be better, and it's the same across all situations. And people who are depressed tend to interpret things through these kind of the opposite of rose-colored glasses, I guess. These negative worldview. So everything negative that happens tends to be, or everything that happens, they tend to see the negative. and they see the world in a very negative, pessimistic way. There's a lot of cognitive errors there. I mean, when you think about cognitive errors, think of things like overgeneralization. One negative thing applies to all situations, or we tend to overemphasize the negative. There are a lot of reasons you didn't get a job. It could be that you were terrible with the interview, but it could just as easily be that they already picked someone for the job, or someone was more qualified, or you know how it is when you apply for a job. Maybe like the manager's cousin got it, or maybe they lost funding for the job and no one was hired for the job, or maybe they really liked you. You just couldn't hire more than one person. So there's a lot of different things out there, but people who are depressed tend to think negatively and they tend to take it on themselves. So instead of just thinking, well, there'll be another job that I might be more qualified for, or I might like more, it's like, I'm terrible. I'm an awful person. I'd be an awful employee. No one's ever going to hire me. I'm never going to get a job. I'm worthless. And that tends to be the way that people who are depressed look at things. So again, that negative cognitive triad, thinking negatively about oneself, negatively about the world, negatively about the future. Some of the other factors that we deal with mood disorders, you tend to have a lot of marital dissatisfaction, particularly in males. And this isn't surprising. You're unhappy with the world. You see everything in a negative viewpoint. You're probably not going to be unhappy, or not going to be happy in your marriage either. In terms of gender differences, women account for 7 out of 10 of the cases. Again, it could be a high representation of just people who are willing to go to treatment. Men are generally less likely to go to treatment. Women also tend to seek treatment more often for things like breakups or problems with friendships, and generally are just sort of more ruminative than men. In terms of some of the social factors that play a role, social support's a big factor. Lack of social supports can predict depression, and access to a lot of social supports, having deep friend networks or good people that you can talk to when you get depressed, can positively impact your recovery and be more predictive that you're going to be successful in dealing with depression long term. So having support networks is very, very important. Whether that's family or friends or support groups or what have you. Let me skip ahead a little bit. Talk a little bit about treatment. For mood disorders, we largely use medications. I'm a psychologist, so it's a little disheartening. I'd rather say we do, everybody has therapy and we treat all mood disorders with therapy, but that's generally not exactly the case, because medications are a quick fix, they're easy, and people see them as being faster, when in reality they may or may not be. But they also tend to be effective. I mean, truthfully, they do tend to be effective. I'll tell you, this is my own personal thoughts or opinions expressed during this video. Do not, those disclaimers that they use, I don't know. This is my opinion, is what I'm trying to say. I think there's a good place for having a combination of treatment, of having medication, also having psychotherapy, cognitive behavioral therapy. I think that's very effective in dealing with long-term. And it also makes people feel better. Some of the antidepressants that are used are the SSRIs, Paxil and Prozac, things like that. Tricyclic antidepressants like Elavil, which are often used for sleep disturbances. MAOI, monoamine oxidase inhibitors, are rarely used sort of a last line of defense, but are useful for some patients. There's a lot of food and diet restrictions that come along with that. Can't drink wines or cheeses or anything like that. And then some of the mixed reuptake inhibitors, which we'll talk about in a second. Medications only benefit about half the population. and only a quarter of those have resumed what we would refer to as normal functioning. A lot of that's due to not being compliant with medications or stopping after one trial. Like anything else, it may take numerous times to find the correct medication for you or the correct dosage for you, and a lot of times people who are depressed think negatively, right? So they think this medication isn't going to work for me. It hasn't worked so far, it's never going to work, so I'm just going to quit going. Same thing happens with therapy. That's the biggest reason that people don't get any effect for psychotherapy. They just quit. But back to the SSRIs, these block the reuptake of serotonin, so there's more serotonin available in your brain. Prozac is the most popular SSRI. It's probably the most, actually I think it is the most popular medication in the world, and it's still very effective and relatively few side effects compared to some of the older antidepressants, which were not as effective, but there still are side effects. And one of the big things with SSRIs is that there's this brief period of time between when you start taking SSRIs and when it actually you start to feel better, that you see a slight increase in suicide risk. The black box warning, it was commonly referred to, probably still is. So there's warnings on there now. And the reason that happens is the SSR, people who are really, really depressed, like the bottom, say 0 to 100, people who feel like a 10 on that scale, who are so depressed they can't even get out of bed, are also not likely to go through with suicide. As people start to feel better and they get to a 25 or a 30, and they still feel depressed, they still feel kind of withdrawn and isolated, but they're able to be more functional. They're able to get up. They're able to do some of those things. That is when your increased risk of suicide, or when your risk really increases. So known as the black box warning. So you have to make it through this period of a few weeks after you start a medication before you'll start to feel better. And so we just need kind of closer monitoring, and also just to be aware that those feelings are completely normal. And if you feel that, if you feel those suicidal thoughts, then you need to find somebody to talk to, or talk to your doctor, talk to your family. The negative side effects are common. The dry mouth, sexual side effects are very common, and a common reason people get off of those medications, stop taking them. Tricyclic antidepressants are super old. Like, they've been around for a long time. Things like Elavil and Tofranol. They have a lot more negative side effects. Drowsiness, weight gain, and people stop taking them. You can also overdose on them fairly easily. You just take way too many. And they cause anticholinergic side effects. So just the dry mouth, some nausea, just you don't feel well. And then you get drugs that have mixed reuptake inhibitors. They also block norepinephrine as well as serotonin, things like Effexor or Lexapro. They have fewer side effects. They're relatively safe. Then you have things like Cymbalta, which is a dopamine, norepinephrine, also serotonin, I believe, who operate on all three receptors. Some of those medications, like Cymbalta, was originally used for pain. Actually, it's very good for chronic pain. But some of these medications have fewer ongoing side effects, have less sexual side effects. So if you're taking, it's the age-old story. You're taking Prozac, and it just like ruins your sex life. That certainly isn't going to make you feel better. It's going to create this whole new source of stress and depression. And so a lot of people have stopped taking it for those reasons. MAOI inhibitors, like I said, they're not, they're very effective, and they don't have a lot of side effects, except they're dangerous in combination with certain things like beer and red wine and cheese. Also dangerous with some cold medicines, so you really have to watch what you're taking with it. So those are generally the antidepressants that we use. Now we also use some other things like Abilify, Geodon, some medications that are typically used to treat, or that are antipsychotics. And we now use those for some very hard to treat depressions. And then we move on to sort of the medications for, someone's calling me now. I'm trying to ignore it, but I have ADHD. It's not easy. The medications that we use to treat bipolar disorder are a little bit different. We use some of the antidepressants, but you have to be careful with some of the antidepressants because they can cause a lot of anxiety, they can cause a lot of irritability. So not all of the medications that you use to treat depression you can actually use to treat bipolar disorder. For example, something like Wellbutrin, which is a medication that's very commonly used to treat depression, you wouldn't treat someone who has bipolar disorder with that because it can be activating, it can cause some anxiety, it can trigger manic episodes. The most commonly used drug for mania is lithium. Lithium is a natural salt, and it is generally the treatment of choice for bipolar disorder. It's very old, it's been around for a long time, and it treats both the depressive and the manic symptoms. It sort of levels people out, so they have the mania up here, the depression up here, and it sort of finds that happy middle ground to just make people feel better. It works about half the time, but it can be very toxic. It can be dangerous. There's a very small therapeutic window, a window between which you get, if you take too little, you get no effect. If you take too much, it can be toxic and it can kill you. So you have to have a lot of blood work and constant monitoring, and you have to be real attentive. You wouldn't give someone lithium and then just stop following up with them because it can be pretty dangerous. Also, we use things like Depakote, which is and Lamictal, which are both medications used to treat seizures, and they seem to be very effective in treating some people who have bipolar disorder. We don't really know why. But it is effective. And we also have electroconvulsive therapy, shock therapy. Another video that I'm going to put on there for you guys is a video of ECT treatment. Historically, ECT has been very violent. You've seen like One Flew Over the Cuckoo's Nest. I just thought like the Netflix has started the new series called Ratched. It's with Nurse Ratched, who was originally from One Flew Over the Cuckoo's Nest in that series. I haven't started it, but it's on my list and I'm going to watch it this weekend. But historically, also Beautiful Mind. There's a series of John Nash, the character played by Russell Crowe, getting an ECT treatment during that film, and it's very disturbing, very violent. It causes a lot of seizures. Now it's a lot easier. It's done in clinics. It is not quite as traumatic. Generally, they'll paralyze most of your body so you don't feel the seizure. It's not as traumatic, but there is the stimulation electrical current to the brain that results in sort of a temporary seizure. It's done on an outpatient basis, so they'll paralyze you. They'll give you the electroconvulsive treatment to the brain. It elicits the shock. The shock goes away. You feel better. You go home. And for whatever reason, that causes an improvement in depression. The theory sort of is that it just jumpstarts the brain and causes it to produce more serotonin, dopamine, and all those feel-good hormones that your brain isn't naturally producing. But that is sort of... we don't really understand how that works. Some of the side effects that come along with that are memory loss, and also it can be very unpleasant to watch, but less unpleasant than it was before. Also, transcranial magnetic stimulation, TMS, is relatively new, but again, something you're doing in outpatient clinics. I'll see if I can find a video of that too. My fiance works at a clinic here in town that actually does TMS. It's very cool. I went in and saw the setup. It's neat. It uses magnets to generate localized electrical pulses, so less effective than ECT for medication-resistant depression, but it can be combined with medication for your side effects, less likely to have the amnesia that goes along with it, so a little easier. In terms of just psychological treatments, we use cognitive behavioral therapy. I'll post some videos of that too that address some of those cognitive errors. So I talked about the job. I'm trying to think of alternative reasons why you may not have gotten the job other than this general negative, distorted viewpoint. So we attack the negative cognitions that many of us get stuck in. I'm not good enough, I'm worthless, and I try to challenge some of those and replace them with more positive thoughts. Also things like cognitive behavioral technique for dealing with depression for someone who doesn't want to get out of bed would just be basically increasing their levels of activity. So encouraging people to get up and go for a walk for 5 minutes a day. Even if you don't feel like it, get out of bed, and then rate your depression on a scale of 1 to 10 before you get out of bed, after you've gone on your walk. And let's see if it improves. Also, just sort of teaching some distraction techniques when things get overwhelming. Deep breathing and, counting from 10 and relatively simple distractive techniques. The animal alphabet. Think of an animal that starts with A. Think of an animal that starts with B. Keep going until you get to Z. And those types of things can be distracting enough that you at least briefly take your mind off the more in the moment some of the worst cognitive errors and distorted thinkings, most catastrophic thinking periods. We also combine some of the behavioral components there, trying to improve, to challenge those cognitions, but also increase positive behavior. So I'm challenging your cognitive errors. I'm also encouraging you to increase your activity and do things that are pleasurable. One of the things with depression is I stop doing things that I typically enjoy because I don't feel like I enjoyed them anymore. So I used to like hanging out with my friends, but when I get depressed, I don't want to do that. So as a behavioral intervention, I'm going to get you to go do that. I'm going to encourage you to go out with your friends, even if you don't feel like it, and see if that helps. Keep a journal, write it down, see if that helps, see if it improves your depression. Because what we know is there's this neurological link. Doing those things, doing activities, going for a walk, going out to see friends will increase the serotonin production in our brain the same way that medication does. In fact, more effectively than medication. You talk about runner's high. You get out and run, and it creates all these endorphins in your brain that can improve depression on its own. So one of the things that we do is those behavioral interventions to try to increase the amount of the neurotransmitters in your brain naturally. Also looking at relationships, dealing with some of the interpersonal stressors that are going on. If you're having trouble in your marriage or romantic relationship, well, let's talk about that and see if we can work through some of those issues. And some of these things have a longer lasting impact than medications. I mentioned that a lot of people prefer that medication. Because we tend to go to the doctor and we get medications for things and it makes us feel better. I always feel disappointed if I leave the doctor's office and they don't give me any medication. Even if I didn't really need it, I would probably feel better. It's like, where was my antibiotic? Where was this and that? But we sort of know that we don't always have to have those things, but we feel better. So with it's like your doctor saying you need physical therapy for your ankle problem instead of pain medications. It's like, what the hell? I came here for medications and you say I need to go exercise. Same thing with dealing with depression. It's harder for people to want to go through the cognitive behavioral therapy and deal with this, although it tends to be short in duration. Like the average cognitive behavioral treatment for depression is about 8 sessions, which can be, as short as a couple of months. Maybe a little longer, but that's a pretty quick turnaround. With bipolar disorder, it's a little bit different. Medications tend to be the primary treatment of choice. It's still the first line. But psychotherapy can be effective in helping to manage some of those interpersonal things, dealing with work problems that are created, or working with the family to work through some of the things that happen when a person experiences manic episodes. So, let's see. I'm going to just look here. And one of the things that, just kind of backing up, that we want to talk about whenever we're talking about depression and mood disorders is suicide. And it is a very real factor of mood disorders. In fact, your textbook said, 11th leading cause of death in the United States, going up all the time. It may actually be higher because a lot of these go underreported. There's a lot of shame and guilt associated with this. The most common, middle-aged white men. Native American populations tend to be higher as well. Also, when you throw in things like substance use, it increases the rates. But there is an increasing prevalence amongst youth. It's the third leading cause of death in teenagers, second leading cause of death in college students. So it is a particular problem for you guys. And 12% of college students consider suicide in a given year. So it is something that a lot of people deal with. It's a very serious problem and something that we need to be paying more attention to, and we give relatively little attention to it. Sometimes I think EKU has done a great job of trying to increase awareness on suicide. There's I don't know if you'll see those things in your email or just kind of read over them, but psychology department in particular does a lot of events throughout the year. This year, like webinars, things like that, on increasing awareness for suicide. Just increasing the likelihood that people be willing to talk about it. Because there's this misconception that people who talk about suicide don't really commit suicide, or people that actually commit suicide don't ever mention it. It just comes as a surprise, and that's not exactly true. Generally, there are warning signs. There are people people talk about it. There are some of those warning signs, and often in retrospect we can go back and find those. Males do complete suicide more often, and females attempt suicide more often than men. The difference is the methodology. Men are more likely to use guns and more lethal methods than women, who are more likely to use overdose and things like that. Some of the risk factors: suicide in families, low serotonin levels, meaning depression. Depression is a risk factor for suicide. Also other psychological disorders, schizophrenia, even anxiety, things like that. Substance use plays a heavy role here. It increases the risk factors. A lot of people who end up dying by suicide have done so when intoxicated. And maybe you can say, which comes first? Are they self-medicating or trying to deal with depression through drugs and alcohol, or the drugs and alcohol increasing the depression? It's probably working both ways, and it's hard to predict. Stress, humiliation is a huge thing. You see that often, especially in younger kids, but also in young adults, older adults. But you think of how many times you've seen teenagers who died, who've committed suicide after being humiliated, often on social media. So it's a huge, huge problem, and I don't think we pay enough attention to it. Past suicidal behavior is also a risk factor. So a lot of times people who end up dying by suicide have tried suicide before or talked about suicide before. There also seems to be this idea of contagion, more than one person in a group committing suicide, and media plays a role there. I remember when I was a teenager, Kurt Cobain committed suicide, and there was this rash of copycat suicides that followed, and you saw the Netflix series 13 Reasons Why. There was a lot of concern about suicide rates increasing in young adults after that, and it is this sensationalizing, romanticizing of suicide that tends to come along here, and also just talking about ways to do it, which can be a little unnerving. So, what do we do about it? I think we normalize it. We get people to talk about it. We encourage people to get help for it. If you have suicidal thoughts, it's completely normal, but it is something to be concerned about, and something you should consider talking to a loved one about. Talk to, a therapist, talk to a crisis line, talk to a professor, talk to someone about it. Who, if they can't help you, can point you in the right direction. Not everyone's equipped to deal with it or know what to do, but you want to talk to someone you feel comfortable with about it and try to get help. And there is help out there. And I'm going to post some resources here that may be helpful if you have someone or you yourself need some assistance with that. If you're dealing with someone who is suicidal, the first thing you want to do is be comforting to them. Try to remove any lethal means they have. If they're thinking about shooting themselves and they have a gun, get rid of the gun. Just try to keep a safe environment as possible, and just be supportive of that person. Get them to talk and get them help as fast as you can. And if it's you we're dealing with, call some of the crisis lines. Call police. Call family members. Just call somebody. If you're religious, call your preacher or pastor. Talk to a neighbor, whomever. The suicide support lines in the slides, but I'm also going to give you some more local resources because I think it's important. But normalize it. This is something that people experience, and it's not something we can ignore, and it's not going to go away. And the thing that we need to do is make depression, suicide, bipolar disorder, make people be willing to talk about it and share their experience, because I think we would all benefit from that. So, like I said, I'm going to post some videos that I think you might find interesting. People talking about their struggle with depression, also some resources, and I think that pretty much will wrap it up this week. And I will, if you have any questions, please reach out. If there is anything I can do, if you need any resources, please let me know. Otherwise, I will see you next week. All right, thank you.